Now I'd like to introduce you to our sponsor this evening, and it's Assisted Living Locators. I'd like to introduce you to John Younger. And John, thank you so much for sponsoring this event.
Pleasure, thank you. There's no audio.
For the past 4 years, they've helped over 500 families in Massachusetts. People love their service, and this is how it works. Families come to them when they need to start looking at different options within senior living. First, they have a quick consultation with you either over the phone or in person, whichever you prefer. You tell them exactly what you're looking for in terms of the care that's needed, your budget, the location, the timing, and any personal preferences you might have. Based on that conversation, they'll send you information on all the communities and homes that fit exactly what you're looking for. They'll send you a link to websites, features, and benefits, as well as the possible fee structure. You can review that at your leisure and then get back to them on which places you'd like to see. John or Maggie will join you on the tours so they can help you by pointing out the best parts of each place and answer questions along the way. It's important to know that this service is 100% free to you. There's no contract and no commitment on your part. If you like what they do, you can continue to use them as long as you'd like. If your loved ones move into a community at some point, they get a small finder's fee from that community. You never pay more by going through them, and there are times when they can even save you money. There are 230 different senior living communities in central and eastern Massachusetts. You're not limiting yourself by going through them. John and Maggie work with all of them. They are 100% independent in this, so they can give you a very objective view of what one place offers versus another. If a place has a good reputation, they'll tell you. If a place is not the best fit, they'll tell you that too. You know your loved ones best, so you pick the place. John and Maggie are here to help you with the search and will save you a tremendous amount of time, frustration, and stress. The goal is to match the right person with the right place at the right time. The sooner you call John and Maggie, the more they can help. John, 508-878-8878. And Maggie, 508-681-3016.
So now that you have learned what we do as a company in our process, I wanted to make sure you understand how we help you as case managers and social workers. What we do is we give you time in your day back. So how do we do that? We will meet with the families as our video showed. But what happens is if you have a patient who's interested in discussing assisted living, who's no longer safe to stay at home, rather than we're offering you an option, rather than you either handing them a list of potential places or you picking up the phone and calling these different places on your own, one phone call to myself or Maggie, or in New Hampshire, Christy or Glenn Badger, and we will be able to help you through the process of helping your patients get into a safe living environment. What we'll also do for you, besides giving you your time back, is we're going to also over communicate what we're doing. We don't want to take this job away from you. We all have the heart of a social worker. What we want to do is get back to you with progress and process. And after the folks move into a nice assisted living, we're going to follow them for 30 to 60 days. And we're going to keep you informed as to how they're doing, even though they're previous patients. So we are a national company. We also offer the opportunity to help your patients relocate throughout New England and throughout the United States. So we're here to help you help your patients. Thank you very much.
Thank you, John. I'd like to now thank Alosa Health for their support of this program, and I'd like to introduce the speakers for this evening. Paul Fanikos. Paul is the Chief Operating Officer at Alosa Health. Alosa Health is responsible for providing leadership and oversight of the organization's academic detailing programs and services. Paul has more than 30 years of experience directing disease and pharmacological education programs that are focused on improving patient outcomes and cost avoidance. Paul has held leadership roles with the country's largest pharmacy providers and pharmacological companies, developing innovative solutions to challenges that impact clinicians, health systems, extended care facilities, as well as home care programs across the country. Paul received his pharmacy degree at Massachusetts College of Pharmacy and his master's degree from Suffolk University. Dominick Trombetta. Dominick is currently an associate professor of pharmacy at Wilkes University, Nebsit School of Pharmacy. He received his Bachelor of Science in Pharmacy from Temple University and his PharmD from Shenandoah University. Dominick's area of expertise is geriatrics and internal medicine, and he maintains an active clinical practice at Allied Services Rehabilitation Hospital in Scranton, Pennsylvania. His responsibilities include the traditional didactic teaching in the pharmacotherapeutics sequence, as well as precepting introductory and advanced practice pharmacy students in geriatrics and internal medicine. He has been a clinical educator at Alosa Health since 2005. And I've had the pleasure of working with both of these gentlemen, and I think you're going to really enjoy the program tonight. They have a wealth of knowledge and experience to share with you. So welcome, Paul and Dominick.
Hello, everybody. I'm Paul. And Dominick, I don't know if you want to come on and say hi as well, just so everybody can see us at the beginning. Or not. Mary Lou, thank you so much for that warm introduction, and thank you.
Yeah, sorry, Paul. It took me a little bit to unmute myself. Thank you, Mary Lou, for the kind introduction, and it's my pleasure to be here with you all this evening.
Thanks, Dominick. So we have a presentation for you today. It's about managing depression in older adults. Mary Lou really gave us a nice introduction about what we do and how we do it. We're going to share with you some of the key findings or clinical trials that have been done over the last couple of years, and some of the information that our prescribers that we go and see have found to be really useful in their clinical practice. Dominick, we can advance. Great, thanks. Thank you so much. We have no disclosure to report, so we're not receiving any funding from any pharmaceutical company or device manufacturer. We're here courtesy of from Alosa Health. Alosa Health is a nonprofit organization that focuses on improving prescribing across the United States. And one of our topics that we've delivered frequently is the depression topic. Dominick, maybe you could talk to them about this slide and take them through this.
Yeah, we have a couple, we have a few questions embedded in this PowerPoint presentation, and we'd like to try the Slido audience response. So if you either take a picture with your smartphone of the barcode, or just log into Slido, that HTTP. And once we get to the question, I'll have a code for you guys. You plug that code in, and we can see the responses right on the screen. So this should be pretty slick. I'm looking forward to it. Take it away, Paul.
All right, I'll give everybody a minute to get going on that. But just to level set with everybody, what is depression? Here's a definition from the American Psychiatric Association. Depression is a serious medical illness that negatively affects how you feel, the way you think, and how you act. Clinical depression causes persistent feelings of sadness or loss of interest or pleasure in activities that one once enjoyed, such as reading or exercising or going to see loved ones, or anything you really normally do as part of your daily activity. It can contribute to a variety of distressing emotional and cognitive and physical problems, and can decrease a person's ability to function in the way they once did. So that's the background of from which we're working with, and it's definitely a serious issue, and more so in the adult population. Dominic, we can advance. What's true is that it's frequently under-recognized in the older adults that we service. And that can be for a number of different reasons. Often it has to do with these categories. Patients sometimes have high medical burden, which impacts the diagnosis, disability, psychosocial issues, and of course some cognitive impairment that goes along with aging. And so frequently those have an interaction between depression, and therefore it's really difficult to notice when somebody is cycling through a depressive episode, and often under-recognized and underdiagnosed. Thank you. One thing that is clear is that it's not a normal part of aging. I don't know how often, probably everybody on this call has experienced that, you go talk to somebody that's caring for an older person or a family member that's older, and they said, oh, so-and-so seems sad today, or they seem down. And then frequently the response is, well, they are old, or almost like it should be expected. But that's not really the case. Depression and presents as a number of different ways in the older population. Some patients have depression their whole life, and it's reoccurring. Some people experience a first depressive episode later in life. Others have it because of a high medical burden. Some patients exhibit it because they have a neurological disorder or deficit. And then sometimes there's this subsyndromal type of depression that's ongoing. And it's just very mild symptoms, but stays with patients for a long time. So one thing to take away from this slide is, though, we shouldn't dismiss it as just a normal part of aging, because it really isn't. We can advance, thank you. A couple of things to consider with depression and comorbid conditions: they kind of go hand in hand, meaning that the percent of patients that have, or the percent of depressed patients frequently have a comorbid condition with them. This bar graph shows some of that percentage for patients that have been studied and revealed. And the one that always surprises me is coronary artery disease and how high it is, because that is something that most adults will eventually get at some point in their life. They'll develop coronary artery disease. And the percent of depression that's associated with that is significantly high. The others seem to make sense: Alzheimer's disease and Parkinson's disease. But then we also have hospitalized patients that have an MI, or patients that have heart failure, which are all things that we see in the older population as well. So these go hand in hand, and as we see patients that have some of these comorbid conditions and they seem out of their normal activity, we should suspect that something else is going on. The prognosis of depression is an interesting piece to take a peek at. As probably everybody knows on this call, the majority of older patients are handled by primary care physicians. And so they will be the first ones that see some of the challenges or diagnosing patients with depression. This is a trial that was published in 2009. And I think there's a couple key takeaways from this trial. One is that the duration of the depression episodes for patients was 18 months in this trial. And that's a sizable amount of time for people to be in a depressive episode. And what's also important is to take a peek at the recovery rates that are here on the graph. That 35% recovered in 1 year, and 60% within 2 years, and 68% within 3 years. And that's a long time for a patient to be experiencing sadness or loneliness. And it's really a challenge for older patients. In this trial, what gives us some hope is that only 40% of the patients were receiving treatment at the beginning of the trial. So there is an opportunity to treat patients and improve their outcomes for depression. And obviously we have some ways to go with recognizing the fact that it's there in the first place. Dominic, we can advance. So the impact of depression, or the burden of it, is sizable in a number of different areas. We can take a look at that slide. If you look at depression, and this is from data from 2015, so it's relatively recent, depression costs over $210 billion annually to society. A good portion of that is in the workplace environment with $102 billion. That is in the form of lost days work or unproductivity of people that suffer from depression. There's a huge amount of medical costs that go with this, with the disease. Drug costs are sizable at over $28 billion, and that's even though there are a number of drugs that are generically available and have been for some time. And importantly, which we'll get into at some point in this lecture, is the suicide cost related to it. So this is a significant personal issue and a significant financial issue for our society. And downstream, issues with depression are sizable as well. Frequently, patients that have depression will have a first stroke or an MI. There's a high level of mortality with cancer patients that have depression and coronary artery disease, as well as a higher mortality with patients that are disabled after a stroke. It increases your risk for dementia. And obviously, suicide in older patients is something of great concern as well. So it affects not only the person and the cost to society, but also impacts their longevity as well. Just touching for a minute on suicide, and that is something that is getting more and more recognition across, I think, society, and particularly this last year, as we've been challenged with a number of issues with the pandemic. But for depressed patients, here's some staggering statistics. Older Caucasian men have the highest suicide rate. It's 4 times the national age-adjusted rate. That's striking to me every time I see it. One would think, that this would be a younger issue for men, and that's truly not the case. The highest risk group is Caucasian men over the age of 85 who are isolated and physically ill. That's a host of patients that we can probably all think of just as we think about the patients we take care of. 1 in 3 elderly patients who commit suicide have had contact with their primary care physician within the preceding week. That is astonishing to me. And think of that for a moment. That means roughly 33% of the suicides could potentially be impacted by intervening at the right time, if we only knew, or maybe if we screened better. And importantly, most older individuals who kill themselves have not had a suicide attempt before. So this is not something that that people plan for. This is something that happens over time, and we'll get into that in a few slides as we move through the presentation. But clearly, again, an incredible number of statistics to think about. Diagnostic criteria. Dominic, why don't I pass this off to you, and you can hit the key components here.
All right, thank you, Paul. So we're going to pivot to talking about diagnosing major depressive disorder, and the core diagnosis comes from the DSM-5, and that tells us there's 5 or more of the symptoms provided should be present every day during the same 2-week period. And one of those, there are 2 that are required, and in the red box, and they've got to have one of these, and a total of 5, either depressed mood or markedly diminished interest or pleasure in almost all activities. You can't really use appetite or sleep because they're not as reliable. So that's why one of the two in the red box are required for the diagnoses. Not advancing. There we go. Okay. So diagnosing major depressive disorder. An easy way to remember, and we kind of use this mnemonic to teach students, is SIGI caps. And each one of the letters in SIGI caps is going to be correspond to the DSM-5. So you have persistent low mood, plus S is sleep changes, I is interest or loss, G is guilt or worthlessness or hopelessness, E is energy lacking or fatigue, C is cognition or reduced concentration, A is appetite loss, P is psychomotor changes, and S is suicidal preoccupation. Is it bereavement or major depression? So there's some distinctive features that you could evaluate, like predominant affect, timing and intensity, associated factors or thought content. And in bereavement, the feelings of emptiness or loss can be accompanied by sometimes positive emotions and humor. Timing and intensity is decreases in time, but it can occur in waves, i.e. the pangs of grief. The symptoms can be associated with thoughts or reminders of the deceased. And thought content, preoccupation with memories of the deceased, self-esteem is generally preserved. They may have a passive desire to join the deceased, but they're not suicidal. In contrast, major depression is the mood is persistently depressed, inability to appreciate or anticipate happiness or pleasure. It's persistent and unremitting, symptoms connected to pervasive unhappiness, and thought content is self-critical or pessimistic, self-loathing or feelings of worthlessness, thoughts of one's own death, focused on undeserving of life, and unable to cope with pain. So as far as screening for depression, the United States Preventive Services Task Force released a statement in 2009 recommending screening for depression in the general adult population. With convincing evidence, patients identified through screening include older patients, can benefit from treatment, and the magnitude of harm is either small or none. Screening tools for depression. We have a PHQ, which stands for the Patient Health Questionnaire 2-question. We have a PHQ-9, and we also have a geriatric depression screen, which I'm sure many of you are very familiar with. So the PH2 questionnaire is very simple. It consists of 2 questions. The first being, during the past 2 weeks, have you been bothered by feeling down, depressed, or hopeless? And the second question is, during the past 2 weeks, have you often been bothered by little interest or no pleasure in doing things? And the responses are graded based upon 3 points. And depending, a score of 3 suggests further evaluation with another tool like a PHQ-9 or GDS. So a positive screen, what now? So next steps, we complete a mental health assessment, obtain additional history, consider safety factors such as suicidality, obtain additional testing and data, and consider a differential diagnosis. With regards to that differential diagnosis, it's important to get the diagnosis correct to avoid negative outcomes and the costs of unnecessary therapies, possible adverse drug reactions, and medication errors. So again, I'm sure you've seen it Depression can coexist with other psychiatric disorders such as bipolar disorder. Psychotic disorders can occur with, in addition to, or with substance abuse disorder, whether it be alcohol or drugs, as well as personality disorder. And as Paul alluded to earlier, it can be associated with a number of different conditions, especially some of the most central nervous system disorders like Parkinson's disease, dementia, the dementias, neoplastic lesions, can be caused by drugs. Endocrine disorders sometimes be the cause of depressive symptoms, and they can be hypo or hyperthyroid, as well as hyperparathyroidism. As also consider infectious inflammatory disease like HIV or SLE, sleep disorders such as sleep apnea, and adverse life events, as we talked about bereavement earlier in the slides. The additional data, cognitive assessment should be evaluated using either the mini-cog, the full STEAM mini mental status exam, or the Montreal cognitive assessment. So any one of those tools can be pretty useful. Laboratory tests, we're looking to rule out other conditions: complete blood count, your basic or complete metabolic panel, thyroid stimulating hormone, B12, folic acid, and of course, an EKG in really high risk individuals. And those people are, patients who have significant cardiovascular histories. They're prone to electrolyte disorders, or they're taking one or more QTC prolonging medications.
Some of the thoughts about depression have changed a little bit over the years, and one of the areas that has picked up steam, we've heard things about like deprescribing in the older population, and obviously medication load. And one of the things that has come up more recently and is getting better traction for not only pain management but for depression as well, is non-pharmacological therapies that are potential options for patients. And a few of them, we'll just review some of them here and give a little bit of a snapshot of some of the core ones. But they really fall into a couple different buckets. One is, psychotherapy, such as cognitive behavioral therapy or problem-solving therapy, interpersonal therapy, supportive therapy, and a few others that are, used. I know that the VA uses some life review therapy and family therapy tools that seem to have utility in their population. And of course, exercise. That's something we want to hit on. And so if we take a look at the next slide, we'll share a little information about some of the studies that have been done that we thought were of high value. This is a study that was done in 2014, and it was a meta-analysis of psychotherapy. And interestingly enough, they found it to be as effective as antidepressants. A meta-analysis is when the authors will pool together multiple studies and then take the data within those studies and pool them to get results. And in this particular trial, the number needed to treat, hence the term NNT here, was 3. So that's really pretty low. So alternatives to antidepressants do exist, and these things do work. Interestingly enough, here on the chart, in this trial, they looked at a couple things that we thought were really interesting. One was they combined the drug therapy and pharmacotherapy together, and then looked at independently the psychotherapy versus drug therapy. And there really wasn't a difference between the groups. So statistically speaking, they were both effective. And that's something to consider when you're thinking about first choices for patients and what they may respond to, or combining items together. Dominic, let's take a look at the next slide. Here is another meta-analysis with 23 clinical trials in it. And in this one, they had a combined 1,800 patients, which means it's sizable. And the average age of the population was greater than 50 years of age. So that means they're heading towards the older adults within their category. And in this trial, they found that CBT, or cognitive behavioral therapy, is effective in older adults, which is nice to know. And what was also important was it was more effective than usual care or waitlist controls. So that's really something to hang your hat on. And as you think about what may work for patients, and what they found is they were 3 times more likely to improve, nearly 7 times more likely to achieve remission. So it always strikes me when I see this data that it's interesting. A lot of times we forget that people are just people, and they're social to begin with. And I guess this year probably tells us a lot about that. We've seen a rise in depression and anxiety as people are isolated. And cognitive behavioral therapy involves a lot of interaction with people. So it has a large social component to it. And that clearly has a significant benefit to it. What also we were compelled by was the fact that this was sustained benefit for 6 months. That's a wonderful thing to know. And obviously, this is becoming more of a treatment option for younger patients, but also now obviously older patients as well. Dominic, we can take a peek at the next slide. Here's one of my favorite ones, and this is about aerobic exercise. And this was a controlled trial with 156 older adults, and they were aged 50 to 77 with major depression, and 80 to 90% had recurrent depression. So that's a good cohort to work with. Obviously, there was some of this group they screened in advance to rule out patients from participation to make sure they were healthy enough, and that's just good practice, good trial setup. And basically, what they did is they had supervised aerobic sessions 3 times a week for 16 weeks, and then they were compared to the drug group. And we had some positive results. At the end of the day, they were as equally as effective as the antidepressants for treating depression, which is awesome to know. And then there is one caveat: the patients that were on medicine had less severe symptoms in depression, and they had a faster response. So a subset seemed to do a little bit better. But we do know that aerobic exercise plays an important role in treating depression. I think the takeaway on this slide is, obviously, if you want to get people up and around, regardless of age, want to make sure that they're healthy enough to engage in some physical activity. But regardless of what age, there is a benefit to it. And also, as a side note, the patients had a greater improvement in aerobic capacity, meaning ultimately they had more physical strength at the end of the 16 weeks. So something to seriously consider when we're evaluating our older population. Dominic, I'll turn it back to you because I know this is your claim to fame.
Thank you. Okay, so we're going to talk about some antidepressant medications. All right, so as you look at antidepressants, you can kind of think about them as maybe 6 different buckets. We have our selective serotonin reuptake inhibitors. We have our selective serotonin and norepinephrine reuptake inhibitors. And we have our atypical agents. We have serotonin modulators. We have tricyclic antidepressants. And we have monoamine oxidase inhibitors. I'm really not going to be talking about tricyclic antidepressants in this presentation, as they are one of the first classes of drugs used to treat major depressive disorder. But because of their tolerance and side effect profile, we kind of tried to avoid using them in our older patients. So I'm really not going to talk to you a whole lot about those. And monoamine oxidase inhibitors, again, we're going to reserve those for specialists to use, because there's a lot of drug-drug interactions, drug-food interactions. So they're not for the mainstream population unless you're treating a significant treatment-resistant condition and they want to try one more medication. So we're really not going to be talking about that to any great degree. Okay, so looks like someone answered the question already, but the poll is still active. And so if in a large meta-analysis involving over 500 clinical trials, 21 antidepressants were found to be effective and differed only with regards to tolerability. So if you join at slido.com, that's our meeting number. And let's see how many people. So far, we only have 2 people who participated. So let's see if we get a few more people to participate. So I have a couple more. So you may want to log in on either your smartphone or your laptop or desktop computer. I'll give it a couple minutes.
Dominic, I was just going to say, this is a lot of restaurants are doing this now. So if anybody's been to a restaurant recently, they have this QR code on the table. And so you just take a picture with your phone and you'll get a pop-up and you just click on that and it brings you right to this Slido.
That's funny. You know what? I was just at a restaurant last evening and they didn't actually have a physical menu to hand out. They actually had this, you had to scan that with your phone to see the menu. So that was pretty wild. So that was the first time I actually had experienced that. But I guess I live in a backward area, backwoods of Pennsylvania.
Doing it now. Yep.
Okay, so it looks like we have about, we have about 16 people who've responded. And yeah, the overwhelming majority have selected the correct answer. So this is true. So they generally were found to be effective and differed only with regards to tolerability. So great job, guys. So the drugs work. This is a recently published large meta-analysis of 522 double-blinded randomized control trial comparing antidepressants with placebo or another antidepressant for acute treatment of adults over age 18. It encompassed 160,477 people with a mean age of 44, with the vast majority of people having moderate to severe depression. Primary outcomes were effectiveness and tolerability. There are 21 individual antidepressants evaluated, and it found that antidepressants were more effective than placebo in adults with major depressive disorder. And effectiveness was defined as a 50% reduction in the severity of depressive symptoms. So as you can see, you have a vertical line going down, and all the data points are to the right of that line. So you'll have your odds ratio going down with the confidence intervals, and you also have the confidence intervals can be visually appreciated by the horizontal line going through the data points. So everything is generally to the right. So that means good news. For tolerability, defined as the overall dropout rate related to side effects, on a whole, SSRIs trended towards the better tolerable than SNRIs and other types of antidepressants. So again, you can appreciate this visually by just looking at those data lines, confidence intervals, and if they cross 1. Give you a couple seconds to just visually appreciate this graph. There's a lot of data, but it really, when you look at this, it's like, oh, okay, now I know. All right, balancing risk and benefit. When comparing head-to-head, some antidepressants were more effective with fewer treatment dropouts. It's not surprising that trazodone had lower response and higher dropout rates, as although it's classified as an antidepressant, it's primarily used for sleep due to its sedating qualities. And then the need for higher dosage range to elicit an antidepressant response is quite high. but drug efficacy is reduced in older adults. This is a meta-analysis of placebo-controlled trials in patients over the age of 55. It had included 74 studies, including more than 20,500 patients. Antidepressants were found to be efficacious in the treatment of late life depression, but antidepressant response rates were influenced by age, which is really interesting. When they split out the patients 65 and older, they did not find the treatment effect to separate from placebo. Some of this result was felt to be related to the small numbers of late life depression studies that encompassed these patients over the age of 65. And the largest trial that was included in this meta-analysis was a negative trial. Other proposed influence of treatment response that was discussed before was the greatest burden of somatic illness that Paul discussed earlier in the slide deck that contribute to depression, ischemic brain disease, executive function. And there's also the tendency of many to prescribe suboptimal doses of antidepressants in our older individuals because you remember the start low, go slow, and then don't go phenomena. That's what we're talking about, I think, here. Another factor may be that older patients may just take longer to respond to antidepressant drugs. Trials of longer duration in older patients showed greater treatment response. In patients over 60, they looked at 10 trials, and they were of 6 to 12-week duration. They found that overall, antidepressants worked in late life depression, with the most notable thing in the study found was that patients responded better overall in the longer duration studies, 10 to 12 weeks, versus the 6 to 8 weeks, with the odds ratio for response being 1.73 in the longer studies versus 1.22 in the 6 to 8 week studies, which you can see in the green boxes. The drug placebo difference in response was also approximately twice as large in the longer studies. So many times I think what occurs is that we turn on the hose and sometimes we forget to modulate that, whether to turn it down or to turn it up to kind of make sure that we're seeing the response that we are going for in this patient population. Some considerations for side effects to antidepressants. Hyponatremia, which is defined as a sodium less than 135, is an antidepressant side effect that disproportionately affects older adults. In a large observational study involving more than 60,000 patients, aged 54 to 100, older patients taking SSRIs versus not had a 52% risk of hyponatremia compared to no antidepressant use. The actual incidence of hyponatremia is not clearly reported, but it occurs commonly enough in our frail elders that gerontologists and geriatric psychiatrists see patients with this issue not uncommonly. When it occurs, it tends to occur within the first weeks of treatment, sometimes within the first few days. Causes are thought to be almost entirely related to the antidepressant or development of syndrome inappropriate ADH secretion, preventing reabsorption of sodium water in the distal tubule of the kidney precipitated by the SSRI. Increased risk of bleeding. Increased risk of bleeding with the use of SSRIs. It's believed that bleeding diathesis is due to blocking serotonin reuptake by platelets, leading to impairment of platelet homeostatic response. Associations between SSRI use and bleeding risk can be confounded by many factors like alcohol abuse, smoking, small vessel disease, as well as diabetes. SSRI exposure has been associated with increased risk of brain hemorrhage, largely due to intracerebral bleeding. Given the rarity of the event, if this association is accurate, it may lead to one additional bleed per 10,000 persons for 1 year. Rates may be higher in patients with past medical history of intracerebral hemorrhage and also patients with concomitant use of anticoagulants, NSAIDs, or other antiplatelet drugs. This association is not clear enough to really influence our treatment decisions, however. Also, another rare event, SSRIs, increase the risk of GI bleeding. There are patient characteristics that contribute to this risk, including advanced age. The older the patient, the higher the risk. History of GI bleeding, history of peptic ulcer disease, concomitant use of NSAIDs, anticoagulants, corticosteroids, as well as antiplatelet drugs. Given estimated global incidence of about 24.6 per 100,000 person years, higher risk of is associated with strong SSRIs, such as fluoxetine, paroxetine, and sertraline, than weaker SSRIs. All right, so which antidepressant has the lowest risk of sexual side effects? All right, join Slido at 312-570. Oh, I noticed we have a lot more activity on this question than the first one. Well, actually less. Interesting. A few more seconds. All right, the correct answer is actually bupropion, C. Okay, so the other SSRIs, escitalopram, fluoxetine, and sertraline, they generally have a pretty high incidence of sexual side effects. So typically, we would change those patients who have major depressive disorder to bupropion if they're experiencing those. Generally, the bupropion is the right choice, is the correct answer in this scenario, as long as someone doesn't have a past medical history of seizure disorder. That's the only contraindication to bupropion use. Great. All right, what about falls and fractures? Studies have found an association between SSRIs and falls and fractures. The risk of this appears to go in descending order of SSRIs, tricyclic antidepressants, and other antidepressants. The increased risk of fractures associated with antidepressant use may be due to increased risk of falls. But some evidence shows potential for reduced bone mineral density in users of SSRIs. But it's premature to label SSRIs as a secondary cause of osteoporosis at this time. Addressing fall risk, so we counsel patients regarding falls prevention, monitoring for sedation, postural hypotension, consider bone mineral density testing in our patients, adequate vitamin D, possibly supplementation, and adequate calcium intake through diet, preferably supplementation for those who cannot meet those minimum dietary standards. Okay, arrhythmias. Escalating numbers of hypothetical QTC prolongation warnings really fly from pharmacy databases. There's no clear national or international guidance regarding how QTC risk should be dealt with, and it's unclear how significant or not the potential QTC prolongation qualities of antidepressants are. Among the SSRIs, there are dose-dependent increases in QTC when compared to placebo, with Celexa having the greatest risk. So that's the one with the FDA black box warning and dosage restrictions in older patients. So for comparison's sake, antipsychotic zisperdone, which increases the QTC by 10 milliseconds, or cardiac agents, sotalol, which increases the QTC by 30 to 40 milliseconds. And citalopram is around 6.1, when, as you can see, tricyclic antidepressants are slightly higher, around 7.1. Essentially, most patients, those with known QTC prolongation or history of torsades de pointe or long QTC syndrome, or patients with multiple risk factors, consider obtaining an EKG before and following the patient after the start of medication. I'm going to pivot and ask Paul to step in.
Thanks, Dominic. A few items to consider when having dialogue with patients about either initiating or maintaining antidepressant therapy. There's a lot of misconceptions out there about these medications and medications in general, and we take it for granted that although we know they're relatively safe compared to many other medications, some people have the thought that they could develop a dependence or addiction to the medications. They're reluctant, particularly men, as probably everybody on this call knows, are willing to share what their true thoughts about or their personal views of depression, viewed as a sign of weakness. Sometimes people are aware that they may have an evening out effect from the medication, which would prevent some real full emotions for people, and they simply don't like that experience. And some people may have tried medications in the past, particularly our older population. And Dominic talked about the tricyclics and some other medications that were once the mainstay, or even some of the earlier SSRIs. They may have had a bad experience with them, such as sedation, or as Dominic hit on, sexual side effects that may stop people from taking their medications. So the core piece here is to set some realistic expectations to try to increase adherence to treatment. As you may or may not know, is that most of the patients stop their therapy after starting it and getting to some remission, and that's not exactly what we want people to do. And I know Dominic has a few more slides on that. Dominic, I think we can take the next page.
Thank you, Paul. Okay, some caveats for late life depression. STAR-D was an all-comers trial, so was not specifically designed for older patients, and the age cutoff was 75, and only 4% of patients were 65 years and older, and 24% were greater than 50. Vigorously dosed antidepressants over a short period of line is not in line with our start low and go slow approach. And that's kind of what they did in STAR-D, is they kind of vigorously dosed antidepressants. And they also used a strategy after they increased the dose to the maximum and there still wasn't a remission, or at least a 50% reduction in symptoms. They used something called augmentation. And they used two augmentation strategies in STAR-D. And one was using busprenone, and the other one was adding bupropion. So there was two different augmentation strategies. However, polypharmacy is an issue in our older patients. So switching to another antidepressant may be preferable in our older patient, rather than adding another drug and adding on to the issue of polypharmacy. Once remission is achieved, continuation and maintenance is needed, and it's important to manage relapse risk. So we use the same medications at the same dose through time to maintain improvement. The more episodes of depression one has, the more vulnerable they are to relapse. So the rule of thumb is, after remission of symptoms, if this is the first episode, you continue the medication at least 1 year. If it's a second episode, you wait at least 2 years. And if it's a third episode, you wait 3 years or more, consider indefinite use. I'm going to pivot to Paul here.
Yeah, thanks, Dominic. I was trying to type. I was trying to answer a chat. I was failing. Suicidality in late life depression is something we all should be concerned of. It's important to highlight it here. It's really difficult to identify at times, but if we can have a huge impact on people's lives, and it's really part of an important part of patient safety and keeping our patients safe. And it's also a sign that, you know, the treatment plan that has been established is not probably working right if we have one in place for a person. So a couple things to consider. Let's take a look at the next slide and give some key statistics about what's going on in the population. This is data from the NIH, and it shares a forest plot type design graph. On the left side, you have female patients, and then on the right side, you have male patients. And as you can see by the darker lines, that in the longer length that those lines have, that clearly the male population has a higher suicide rate than females in the United States. And also it's tiered by age. And as you can see at the top of the graph, the patients older than age 65 is the highest rate for males in suicide, where it's one of the lower rates for females. So clearly something's going on with our male population above the age of 65. And obviously it's a risk all the way through for men, more so than women. And what is probably important to note is that men are more successful at suicide than females. It's probably has to do with the choice that they use. They usually use more violent choices than females, and therefore they have more of a successful outcome, which is obviously not good news. On the flip side, women have more attempts than men, but are clearly not as successful at it. And again, it comes back to the choice. Here's a nice graph that you can, thanks Dominic, that was great. You can take a look at what's most oftenly used in successful suicides. The two graphs on the left part of the page are segmented by color, and suffocation is high, you know, poisonings are high, higher for women, but firearms, that's clearly the men's choice. And interestingly enough, in the United States, about 40% of the households in the US have a firearm. So it's a good question to ask people as a preventative measure if they do have one. Having one increases people's risk of suicide. And, you know, 51% of the suicides in 2014 were a result of firearms. So again, another sizable statistics. And this one's the most compelling is, you know, somewhere between 80 and 90% of attempted suicide with a firearm are successful. So, and a very effective piece, but obviously something we need to talk with patients about. And, you know, we've done some work with the VA, and one of the things they do is they develop a safety plan for patients when they think they're at a suicide risk. And one of the things they do is they try to ensure that the gun or the firearm gets separated from the patient, either, you know, hopefully voluntarily, where they'll give it to another loved one or a caregiver to take it away from them and maybe give it back at a different time. And another thing that they often do is they will give out gun locks. A gun lock is a great tool to slow down somebody's thoughts about suicide and protecting people also in the household. So for really some work we have to do in that front across the United States, and particularly with men. Dominic, you can advance. There's a nice tool called the SAFE-T. It's a 5-step assessment of suicide. And it's something that psychiatrists use frequently in their evaluation of patients. It consists of these 5 steps. One is identifying risks, identifying protective factors, those being items that are positive in people's lives, whether they're children or a particular job or work or hobby. Number 3, conduct a suicide inquiry, and to do that completely. 4, determine the risk level and select an intervention type for prevention. And then finally, 5 is document it. We're going to spend time on 3 and 4. This would be a whole lecture in itself, but I wanted to give you a snapshot of 3 and 4. And those are on the following slides. And we can talk a few minutes about that. So conducting a suicide inquiry for individuals who have self-harm or suicide thoughts, consider it an escalating risk, meaning they don't make these decisions out of the blue. It's usually a planned behavior, and it's on a continuum, almost like a path. And the path consists of these items: ideation, a plan, behaviors, and then intent to carry out. And so catching a person in each one of these phases is helpful for prevention. And asking good questions can help do that. A couple examples here for ideation are, for one, have you ever felt that life was not worth living? And that's a great catch, right? If somebody answers that, that gives you the trigger to ask more questions subsequently. If they're developing a plan, it's simply asking them, have you made specific plans to harm or kill yourself? And obviously saying it in a nice way, in a compassionate way, is actually really impactful to get people to open up. If you gloss over it, they're more likely not to talk to you about it. So, doing it in an empathetic way is the key to that question. In behaviors, have you made any particular preparations? Or have you ever started to harm yourself but stop before doing something? And that tells you the type of actions that they're prepared to do. And then finally is around the intent. What is the extent of the patient intends to carry out a plan? Sometimes you can talk to them about it and you might hear things like, oh, I was going to take a lot of Tylenol. And some people took Tylenol because they thought it was a safe drug and there wasn't really intent behind it. They just almost, weren't quite sure what they were doing. Whereas some people know clearly that, oh yeah, if I take enough Tylenol, I will die. So those are clearly two different paths for people. So conducting a suicide inquiry, and asking some key questions for patients is a critical step to identifying patients at risk. Dominic, next slide. And once we determine somebody at risk, the next part is, the level of, or what do we do with the patient? And so there's really 3 levels: there's low, moderate, and high. And obviously the first one is the suicide attempt or persistent ideations with strong intent or suicide rehearsal. Need to get them immediate help. At the VA, they will funnel those patients right into an area for mental health services immediately. And we don't necessarily have that luxury here, but we can take action immediately by notifying people about what our concerns are. Second is moderate. They have a suicide ideation with a plan, but no intent or exhibiting behaviors to do it. So they're kind of on the step towards some type of action. And this also should require some hospitalization, depending on potential risk factors, but clearly need a crisis plan or prevention plan for the patient. And finally, there's low risk. They have thoughts of death, but no plan or intent to carry out a suicide. And those patients need outpatient treatment and referral, and to provide crisis resources for them. So really challenging. The first step is ultimately, asking good questions to try to get to some idea or actions that people have, so we can put a preventative plan in place. Dominic, I'm going to flip it back to you.
Thank you, Paul. So some considerations beyond STAR-D. SNRIs differ from SSRIs from one another based upon how vigorously they inhibit the norepinephrine transporter. Among the SNRIs, venlafaxine is the least potent inhibitor of norepinephrine transporter. So there's value to trials of SNRIs. So in other words, if a patient does not respond to an SSRI, well, let's try one of the SNRIs. So when STAR-D was done, venlafaxine was the only available SNRI. And at this point in time, we have a number of options: duloxetine, desvenlafaxine, and levomilnilsopran. So we have a number of options. We also have 2 new serotonin modulators, vortioxetine and belazidone, and also a strategy that was beyond the STAR-D trial was augmentation with atypical antipsychotic agents. And I'll be talking about that in a little more detail on subsequent slides. So I'm sure you've seen many commercials with regards to adding a antipsychotic agent to your current depression treatment on television. We traditionally think of the antipsychotic agents as potent blockers of dopamine D2 receptors specifically. Oversimplified, traditional psychotic symptoms were thought to be related to increases or excess of dopamine in certain areas of the brain. And antipsychotics reduce these levels, and therefore that's how they work. First generation antipsychotic agents are potent D2 blockers and have little or no effect on serotonin receptors. However, this new second generation antipsychotics, or sometimes we call them atypicals, they have little to no effect, or they have a higher affinity actually for the serotonin receptors than dopamine receptors. So second generation antipsychotics have varying actions, and as a class, they're vastly different from one another and have less selectivities in their actions. And that a factor contributes to their side effect burden. These agents carry a much higher side effect burden than antidepressants. So we generally would like to see the augmentation strategy done by psychiatrists rather than general practitioners, just because of the side effect burden with the second generation antipsychotics. And I'll be talking about those a little more specifically in a little bit. Because if you're going to be utilizing a high risk medication in older patients, you really want the benefits to be clear, robust, and consistent in order to outweigh the risks. So that's kind of why we're thinking these may be best for those patients who are treatment resistant and have tried a number of different drugs, and now they need to be referred to psychiatry. So the metabolic effects I'm talking about, I'll talk about a little more detail next slide. Okay, I have a question here, sorry. So which of the following are possible side effects from second generation antipsychotics? So this is a tough question because I'm asking you to check all that apply. Again, slido.com, code 312570. Awesome, you guys nailed it. It's all of them. Get some more time. Some people. Okay, so as I said, the answer is all of these. They can cause Parkinsonism, they can affect blood sugar, they can affect blood lipids, and they can also, certain agents can also affect serum prolactin levels. Generally, those kinds of things cause breast tenderness or pain in men, or they can cause menstrual irregularities in younger women. So we need to screen patients for side effects to antipsychotic medications, and at each appointment evaluate for extrapyramidal symptoms, dystonia, Parkinsonism, akathisia. So this could happen over, it doesn't have to happen over a very long time. I see it, you can see it very quickly in many patients. Screen all patients for tardive dyskinesia. I think this is something that we've routinely done with first generation antipsychotic agents. So I'm most familiar with the AIMS screen. I'm sure there's at least a few more, just as long as we're consistently using the same screen to evaluate and reevaluating patients on a periodic basis. And metabolic monitoring. So as I said, this is a mixed bag of drugs, and we need to measure, check blood pressure, fasting lipids, blood glucose, A1C at baseline, 12 weeks, and then annually. Again, weight as well, first 3 months, and then annually. So these are a diverse group of drugs, and that clozapine and olanzapine probably are the worst in terms of metabolic changes. Lurasidone and zisperdone have less metabolic changes. The prolactin is probably worse with risperidone and paliperidone. And the QTC prolongation is definitely a problem for the zisperdone as well as haloperidol. And if you're looking at sedation, aripiprazole is less sedating. In fact, could cause insomnia. So we don't like to give that at night. We prefer to give that in the morning. And paliperidone is also less sedating and probably should be given earlier in the day as well. There's limited safety data for antipsychotic augmentation in depression. In people with dementia, antipsychotics have been associated with increased mortality, and it can be due to infection, cardiovascular side effects, whether it be MI or stroke, or possibly even QTC prolongation or sudden cardiac death. So we do see the big black box warning on all antipsychotic agents in patients with dementia. So some concluding thoughts. Depression is not a normal part of aging. Depression is diagnosed using the DSM-5 criteria, but additional considerations may be needed in older adults. Psychotherapies are effective for late life depression and may be considered as first-line treatment, as Paul had discussed. Antidepressants are efficacious for late life depression, but impact may be less robust in older patients. The particular drug is not as important as following a rational plan, and that means giving the antidepressants in appropriate doses, monitoring the patients regularly for symptoms and side effects, adjusting the regimen after an adequate trial, and again, trying to continue long enough. And I think we just need to be upfront with patients when we discuss antidepressant therapy, and that they're not going to feel better in just a few weeks. It's going to take maybe 8 to 12 weeks, especially in our older patients, and refer to a specialist in issues on ongoing treatment resistance or safety concerns. So at this time, I'm going to stop sharing and ask what questions you may have.
So I have one question. Are there any studies or is there any information on the effects of EMDR, eye movement desensitization and deep reprocessing? Do you know anything about that?
I have not seen any, but that doesn't mean that it doesn't exist. I know that electroconvulsive therapy is becoming more widespread and much safer. And we see that as being an excellent option for especially those really catatonic patients. And even larger centers are starting patients off with ECT and continuing with transmagnetic stimulation that's not as invasive and seems to be maintaining the remission in the depressive episode. So I've seen a lot of data in those regards, but not this one that you mentioned. I'm sorry.
Yeah, I haven't heard a lot about that one either, Dominic. I know that I've talked to some people from the VA and they've done some work in that area, but I don't know how successful it's been. So I do know that it's out there.
I think it's fairly new. There's probably not a lot out on it. It's sort of a similar therapy to CBT, I think, and there just hasn't been enough work on it maybe yet. So I didn't know. Let's see if we have another. Is it depression before dementia or dementia then depression? Always thought they went hand in hand.
That's a great question. Chicken or the egg, right? So you don't always see them consistently, and depression sometimes is, you know, not always associated with dementia. I've seen a lot of patients that have, you know, pretty moderate cognitive impairment without being depressed. So it's not everyone. I do see it commonly, but I'm not sure if there's an actual correlation. Are you aware of any, Paul?
No, they just, you know, as you mentioned, seem to go together like a hand and a glove, you know? But I don't know of anyone that says, it seems that if you have, you know, depression, then you end up more frequently with dementia. But I don't think there's a clear hard and fast rule about that.
Yeah, because there's clearly a number of patients that are not depressed and just have cognitive impairment, and they may be apathetic. And I think there have been trials done on patients who are apathetic, and really, unfortunately, nothing works. Antidepressant, methylphenidate, nothing really works well for those patients, unfortunately.
I have another question. It's Wellbutrin. I don't see it very often. Is there a reason why it's not used, or I don't see it as often anymore?
Actually, Wellbutrin is bupropion, so I still find it used pretty frequently in treatment of depression, possibly maybe more so in younger patients. I'm not quite sure, but it's still a really useful drug in our older patients as well. So it may be just, you know, demographics, but I still see a good amount of bupropion being prescribed and used in our older population. They seem to tolerate it pretty well.
Yeah, well tolerated. No doubt about that. See it, you know, for smoking cessation and some other things as well.
Okay, I have one more. What if an SSRI doesn't work? Should you move to an other or different kind of antidepressant?
Yeah, that's kind of what they did with STAR-D. If they didn't see a response, they generally switch to another drug. And the suggestion is, well, if they're on an SSRI, maybe try an SNRI. There's been a lot of work in the area of pharmacogenomics, and unfortunately, they're not quite, the science isn't ready for prime time yet. Really isn't quite predictable. Just because someone has a gene and may make them less able to respond to a certain drug, it doesn't mean that that gene is going to be actually manifested or actually you know, be a real you know, concern or a problem in that patient. So unfortunately, we don't have those answers yet.
That's all the questions I have in the Q&A. I don't know if there are any more out there. Oh, I got another one. What if an oh, I just gave you that. We'll tell the study on exercise to my aging parents. Thank you.
Go ahead, Paul.
Now,
I enjoyed that one too.
Yeah, like I often think, you know, a lot of, you know, if you think about our older population, they are a little bit isolated more so than ever before. And exercise gets them out and about. Frequently, I hear stories about, you know, people that, you know, go to the laundromat to, you know, get their laundry done, or they, you know, go to the post office to mail a letter. And it's just some small pieces. You know, they're all anecdotal to me, but they all seem to be keys with key items that seem to make the older population a little bit happier, a little bit more well-grounded. So social connections, exercise, all good things.
Can you talk, or do you have any information on pseudodementia?
Dominic, on that one, I'll pass that.
We really didn't talk about that. Sometimes, you know, I'm not sure if they're talking about situational depression, in which patients, you know, possibly, you know, after they've had a medical illness, or possibly they've, you know, they have had a, you know, been in the hospital for a while, and, you know, they may be situationally depressed, but, you know, generally they don't really meet the full criteria for major depressive disorder. So those patients we generally don't treat for major depressive disorder.
I think we have answered them all. I didn't know, Paul, if you wanted to take a couple minutes to just talk about Alosa and what you do, what Alosa Health is all about.
Sure. Thanks, Mary Lou. So, as I mentioned earlier, Alosa Health is a nonprofit organization. We've been in existence since 2004. And our founder is Dr. Jerry Avorn. He's a professor of medicine at Harvard Medical School. And what he noticed was that the pharmaceutical industry was very effective at getting prescribers to do things different. And so he studied some of their activities and said to himself, I wonder if we could do this for a different type of approach, not just to sell a product, but to actually promote the well-being or best case scenarios of what to do with certain disease states. And so he started studying it back in 1983, and he found out that, in fact, that you could improve the way physicians use antibiotics. You could improve the way physicians use particulate testing, and use it more appropriately through sitting with them and educating them about the best guidelines to do those things. So once he published his data, what he found is people started to call him and ask him who does these things, who could help them run a program. And there really was nobody at the time, so he established Alosa Health in 2004 to help mostly public payers address some issues around prescribing. And since then, we've done probably 25 to 30 different topics, from this one that you saw today, depression, to things like COPD and antiplatelets, or how to manage atrial fibrillation. And what we do is we bring the best and most recent evidence to prescribers and their staff, nurses, and case managers like the ones we're talking to today, and share that evidence, and hopefully they'll make some better choices about the best way to care for their patients. And currently we're doing a lot of work in the public health sector, and we're doing a lot of work in the opioid space right now, as everybody on this call probably is familiar with. If doing case management work, they probably have a lot of patients that are on disability or disabled, and they're trying to manage them back to health. And sometimes opioids have played a negative role in achieving that. So we've been around for a while, and we enjoy the work, and we enjoy talking to people that are caring for patients so that they can maybe do a little bit better. And that's what our sole goal is.
Thanks, Paul. I think that's helpful for people to know that, and you connect to people in a way that no one else really does at this point. So it's great work.
Thank you, Mary Lou.
And I think Maureen, are you on? I think we're close to the end of our program. I don't see any more questions. I think